injury in hypertensive disorders in pregnancy. So introduction is basically acute kidney injury during pregnancy is a public health problem. It's a significant cause of maternal and fetal morbidity and mortality. It is associated with a decline in kidney function. It resulting in a chronic kidney disease and end-stage kidney disease, that is ESKD, and increased risk for the adverse cardiovascular events, higher health care utilization, and a longer hospital stays. Although the incidence in pregnancy-related AKI is very low in developed countries due to improved prenatal care, but it's also very, very important. The introduction, basically, the pregnancy results in increased blood volume, decrease in a systemic vascular resistance. It is increased in cardiac output. It is hyperfiltration, intrarenal vasodilatation, increase in effective plasma flow, and glomerular filtration rate increased by 40 to 60%, because all these changes occurs during the pregnancy in a kidney functions, and there is a physiological reduction into the serum creatinine. So there are different causes for acute kidney injury in a pregnancy, and that also depends upon the timing, at which timing that acute kidney injury can happen during that pregnancy. Then there are signs, symptoms, and what are the causes and what should be the treatment option. So number one is the causes is hyperemesis gravidorum, which normally occurs in the first trimester, intractable nausea, vomiting. There is a volume depletion, possible acute tubular necrosis. So the treatment option are oral dehydration, IV hydration if necessary. Then septic abortion, that also happens into the first trimester, fever and abdominal pain, septic acute tubular necrosis, broad spectrum antibiotics, and surgical removal of the products of the conception is the treatment option. Then preeclampsia, eclampsia, after this is 20 weeks, new onset of hypertension, that's a diastolic blood pressure is more than 140, and systolic blood pressure is more than 140, and diastolic blood pressure is more than 90, and there is a proteinuria. Then why it causes endothelial damage, coagulopathy, thrombocytic microangiopathy, possible acute tubular necrosis. Treatment option, supportive care, delivery when able, and expectant management of the preterm pregnancies. These are another differential causes of acute kidney injuries in pregnancies are urinary tract infection and acute pyelonephritis, which is more common in 20 weeks. Flank pain and dysuria are the signs, symptoms, and pre-renal AKI secondary to infection, possible cause of acute tubular necrosis and directed antibiotic therapy. HELLP syndrome late into the second, third trimester, hemolysis, elevated liver enzymes, low platelet can be seen, and concomitantly preeclampsia. It causes endothelial damage, coagulopathy, thrombomicroangiopathy possible, acute tubular necrosis. Delivery when able, imaging for the right upper quadrant to rule out the hepatic bleeding, hypertension, control if severe. Then thrombotic thrombocytopenic purpura, HUS, usually late second trimester or the first trimester, third trimester initially. For TTP, commonly postpartum HUS, and there is a hemolytic anemia, thrombocytopenia, and a neurological abnormalities. There is a thrombotic microangiopathy, they are the cause, and the plasma exchange or the right rituximab is the treatment part. Then another causes to differentiate between the acute injury in pregnancy are lupus nephritis. It's a delay in pregnancy recommended after 6 months of the disease quiescence, kidney manifestation more common postpartum, extra renal manifestation are common in second and third trimester. Lupus flare diagnosis markers of the disease actively such as known as the competent level, presence of double-stranded DNA, and a proteinuria. Increased disease activity worsening the kidney functions. Treatment, immunosuppression, hydroxychloroquine during pregnancy. Then the obstructive uropathy, second and third trimester, worsening abdominal pain and oliguria, reflux and obstruction cause the hydronephrosis, analgesics, increased fluid intake, stent, and a precautious nephrostomy tube if the conservative management is unsuccessful. And then the placental abruption, placental hemorrhage, That can be in the third trimester, increased vaginal bleeding, abdominal pain. These are the signs and symptoms. They can cause the renal cortical necrosis and a pre-renal acute kidney injury from acute blood loss, anemia, controlled bleeding, supportive care, and delivery of the infant. And the postpartum non-steroidal anti-inflammatory drugs sometimes used, and they are in a postpartum, no specific symptoms, elevated creatinine, bland urine analysis, worsening pre-renal AKI in setting the hypovolemia, and NSAID-induced vasoconstriction. Stop NSAIDs, increase hydration, and supportive care is important. Now, a recent Canadian report, the most common reason for the AKI in this study induced the preeclampsia, thrombotic microangiopathy, heart failure, sepsis, and the postpartum hemorrhage. A study from India, in contrast, showed that the mortality rate for the pregnant women requiring dialysis was 18.3%, of the which 9% remained on the dialysis 6 months and later. The most common reason for AKI being a post-abortion sepsis. Chinese study, on the other hand, determined the incidence of 0.11% of the pregnancy-related AKI, with no women requiring dialysis between the year 2004 and 13. The outcome data are quite variable throughout the world, and prevention and close monitoring remains the meta-analysis in the progress of these women. Now, how to say this is the diagnosis of AKI? It has not been standardized either in the practice or research. The definitions can range from increase in the serum creatinine to the need of dialysis. The further confounded by the physiologic decrease of serum creatinine is seen in a pregnancy. So, diagnosis is frequently cited by RIFLE, R-I-F-L-E. R is what is the risk, then how the injury can happen to the kidney, what is the kidney failure is there, then the loss and the end stage of the kidney disease, and these are the RIFLE, R-I-F-L-E. So, acute kidney injury network criteria for the non-pregnant population have not been well validated in pregnancy, and more recent obstetric studies, however, have begun to use these classifications. For example, having high RIFLE class predicted high mortality in obstetric patients in the intensive care unit. Investigations from the Mayo Clinic using the AKIN criteria discovered that the most of the patients belong to the AKIN stage 1 category with only transient increase of the serum creatinine. So right from the serum creatinine to patient reaching to the dialysis is the way of putting things. Now, women with AKI tend to have comorbid conditions such as hypertension, diabetes, chronic kidney disease, and pregnancy-related complications such as preeclampsia, HELP syndrome, that is, HELP is a hemolysis, elevated liver function, and low platelet. Investigators will be able to assess whether they can be used as a stratify obstetric patient, as more studies utilize when these criteria are there, and hemorrhage and infection is also comorbid condition for having a AKI. Now, different and numerous etiologies of AKI in the pregnancy usually categorize AKI into pre-renal, renal, and post-renal etiologies in the non-pregnant population. So, for the prenatal causes, generally the hemodynamic disturbances that starts the reversible reduction of the glomerular filtration rate, leading to ischemic acute tubular damage and resulting into the irreversible cortical necrosis in the most of the extreme cases. For prenatal causes, these insults include but not limited to massive hemorrhage, adrenocortical failure, amniotic fluid embolism, acute fatty liver in pregnancy, septic abortion, and chorioamnitis. Pyelonephritis and a puerperal sepsis are the causes which we should differentiate for this. Acute cortical necrosis resulting from severe hypertension, pathological diagnosis based on the presence of diffuse or patchy cortical necrosis on the renal biopsy, with intravascular thrombosis in the intralobular and afferent arterioles while sparing the medulla, and this can also be troublesome. Now, the highly morbid, it usually leads to permanent kidney failure, and the reasons for the ACN occur in association pregnancy is unclear. One proposed mechanism is that pregnancy is a hypercoagulable state. There is an increased level of coagulation factors in phase to repress the fibronetic state. So, this, in addition to trigger is present, there is a series of complex self-perpetuating vasomotor and humoral phenomenon follows the system such as coagulation, renin-angiotensin, and a complement pathways will be activated. Renal recovery is unlikely to occur if these triggers are complicated by disseminated intravascular coagulation, that's DIC, and the incidence of pregnancy associated with ACN, in addition to pregnancy-related AKI, however, is decreasing. An Indian study showed that a decrease in the incidence of 4.7 to 0.5% between the years of 1984 to 2005. Now, causes of AKI in pregnancy is a pre-renal hyperemesis gravidorum, hemorrhage, heart failure, intrarenal acute tubular necrosis, acute cortical necrosis, acute fatty liver of pregnancy, preeclampsia, HELP syndrome, and thrombotic thrombocytopenic purpura, atypical hemolytic uremic syndrome, and pyelonephritis, amniotic fluid embolism, pulmonary embolism, and lupus nephritis, acute interstitial nephritis. This is really a big list, and they can cause AKI in a pregnancy. Post-renal hydronephrosis due to the uterine compression, injury to the ureters and a bladder during C-section, ureteral obstruction from the stones or tumors, obstruction of bladder outlet can lead to post. Now, the timing of AKI is very important during pregnancy, may serve as an important clue as the underlying etiology. First trimester frequency is due to septic abortion, lupus nephritis. In second and third trimester, due to the hypertensive complications such as preeclampsia, HELP, TTP, and HUS, then abruptio placentae, severe hemorrhage of DIC or the AFLP. Atypical HUS, however, generally occurs late in the third trimester or the postpartum. These diagnoses may be obvious but may exhibit overlapping features such as preeclampsia and HELP, lupus nephritis, TTP, HUS, and AFLP, making the diagnosis more difficult. Now, this is the timing and what are the main causes of AKI depending on the timing of the occurrence in the pregnancy is very, very important for the treatment and everything. For the early, there can be septic abortion, hyperemesis gravidorum, but mostly between the 24 to 36 weeks is abruptio placentae, hemorrhage, sepsis, preeclampsia, HELP syndrome, acute fatty liver, then TMA deficiencies, then CAP dysregulation TMA and TMA of the unknown mechanism are the one of the reasons. Now, signs and symptoms overlapping on the syndrome injury in a pregnancy. Now, these are things: preeclampsia, TTP, HUS, AFLP, and APS and lupus flare. Timing less than 20 weeks. TTP higher incidence in second trimester. HUS mostly in the postpartum. AFLP higher incidence in third trimester. Then APS can occur in all gestational age, and lupus also flare in all gestations. TTP is thrombotic thrombocytopenic purpura, HUS hemolytic uremic syndrome, AFLP is acute fatty liver of the pregnancy, APS antiphospholipid syndrome. Now the blood pressure more normally this preeclampsia 3 plus 0 to 3, HUS 2 plus 0 to 2 plus this, and 0 to 3 plus with a proteinuria. The neurological involvement, again there is a difference right from 0 to 3 plus, 2 to 3, 0 to 1, 0 and 0 to 3 and 0 to 3 plus. Fever, in most of the cases, in preeclampsia there is no fever, but rest of the time there is a fever, not in APS. Schizocytes are found and they are not found in AFLP and preeclampsia, but remaining, and lupus, but remaining schizocytes are available. Now the low platelet count is in all the cases except less low platelet count. It's almost every cases there is a low platelet count. Then elevated liver enzymes, there is no change into the liver enzymes in TTP and HUS and AFP and lupus, but there is a change in the liver enzyme in a preeclampsia and AFLP. Then proteinuria again, that's all the proteinuria, only in AFLP there is no proteinuria, otherwise proteinuria is there but less in AFLP, remaining all is there. Then AMTS13 activity less than 10%. It's almost every in 3 plus, it's a differential diagnosis for the TTP and HUS, and because it is absent in AFLP, APS and lupus flare. Treatment, delivery of the fetus, preeclampsia help, TTP, plasma exchange, HUS, plasmapheresis, and eculizumab, AFLP, delivery of the fetus, APS, aspirin and anticoagulation throughout pregnancy, and in lupus flare, immunosuppression is needed. Now, there is an atypical hemolytic uremic syndrome in pregnant patients in the age of eculizumab. Is a 90% HUS cases are associated with diarrhea, but the recent studies suggest that 86% of these patients have an underlying mutation in ACP genes, complement regulatory protein mutation in the gene encoding factor H, factor 1C3, and there is a membrane cofactor protein. And a combination of them have been described in pregnancy. Now, the treatment for the atypical hemolytic uremic syndrome in the pregnancy is the therapy similar to the non-pregnant patients, is the plasmapheresis, treatment with eculizumab and immunized monoclonal and anti-C5 antibodies that selectively targets and inhibits the terminal portion of the complement cascades. Now, the medication cost may be justifiable for the subset of the patients with a mutation of ACP genes in a recurrent pregnancy losses due to early and severe HELLP syndrome. So the drugs which are being used, niraparib, amoxicillin, cefoxitin, and cefodoxamine, and they can be given according to their dosage, and they come into the everyday. Same with the ceftriaxone, cefepime, azithromycin, piperacillin, tazobactam, and a meropenem should be used for this. Now, the post-renal AKI is the post-renal causes of AKI are uncommon in pregnancy. Urethral and bladder outlet obstruction should always be considered with a non-pregnant population, and iatrogenic injury to the bladder and urethra are extremely rare and are usually a result of the emergent C-section. Now, incidence of the iatrogenic injuries range from 0.0016 to 0.94 in different parts of the world. Women are at the highest risk are those with ectopic kidneys, duplication of the ureters. Another rare cause of obstetric uropathy in uterine compression of the ureters, typically at the uretero-pelvic junction. Then obstruction uropathy with the uterine compression showed it has a high fetal mortality, 33%, and the risk factors include first and twin pregnancy, solitary kidneys, and the polyhydramnios and the nephrolithiasis. All cases were diagnosed between 29 to 30 weeks of gestation, and treatment depends upon the underlying etiology and the gestational age. Then the patients who were too early for the delivery had an amniotomy for polyhydramnios, placental or ureteral stent, nephrostomies are the hemodialysis, and for the obstetric nephrolithiasis, treatment of the ureteroscopy has been shown successful, although the safety needs to be validated. Now, the management is a general measure to treat pregnancy-related include identification of the cause, volume resuscitation, prevention of the further injury, timely initiation of the renal replacement therapy, prompt delivery of the fetus is there. Steroid and immunosuppressive therapy may be warranted for the biopsy, proven cases of glomerulonephritis, diagnosis of severe preeclampsia, HELP, AFLP, prompt delivery of the fetus is recommended. Treatment of TMAs, including TTP or atypical HUS, requires plasmapheresis, administration of eculizumab for the atypical HUS, and administration of glucocorticoids is indicated should delivery of the fetus be required prior to 30 weeks of the gestation in order to reduce the risk of neonatal respiratory distress syndrome. The conclusion, although the overall incidence of AKI in pregnancy in the world is declining, absolute number of deaths of the AKI remain unacceptably high. Diagnosis of pregnancy-related AKI is not always straightforward and be quite challenging to those with overlapping features such as preeclampsia, HELP, AFLP, HUS, TTP, atypical HUS, or the lupus nephritis. Clinical judgment and experience become a paramount making the accurate diagnosis. Measuring angiogenic factors may prove to be helpful and making the diagnosis of the preeclampsia. Conclusion, sophisticated genetic and serological testing have been potential to help the identify patient with the AFLP and atypical HUS, but they are presently not available for everyday clinical use. Excluding the use of eculizumab for atypical HUS and plasma exchange for TTP, treatment of the AKI is generally supportive, often coupled with the expected delivery of the fetus. Research should focus on the disease-specific diagnostic markers and awareness that from the availability resulted necessary to affect the management decision and impact outcome. And these issues are especially relevant if the incidence of AKI is increased in the developed world, with the rise of possibility related to trend towards delaying the childbirth, which may be accompanied by increased maternal comorbidities. Increasing use of reproductive technologies and frequent result of multiple gestation may also increase the risk of AKI. Need of prompt and accurate diagnosis, followed by appropriate treatment of pregnancy-related AKI, continues to grow with the change of epidemiology of the women of reproductive age. Thank you so much for the patient listening. Though the acute kidney diseases is not very common, but for theoretical knowledge and the differential diagnosis, one should learn about this thing. Thank you so much.